Hello, I'm Dr. Ann Bass. I'm a multiple sclerosis specialist based out of San Antonio, Texas. I'm here today with Caylee, who is living with RMS and is dedicated to sharing her journey and talking about a treatment option that works for her.
Hi.
Before we jump into our discussion, let me note that KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis in adults, including clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease. KESIMPTA is contraindicated in patients with active HBV infection or history of hypersensitivity to ofatumumab or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reaction have included anaphylaxis and angioedema. Warnings and precautions include infection, injection-related reactions, and hypersensitivity reactions, reduction in immunoglobulins, and fetal risk. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions. Caylee, thanks for being here. I know that you have quite a busy schedule.
Yes, I'm a college volleyball coach and I love the outdoors. And of course, I'm an MS advocate, which definitely keeps me busy.
Now, Caylee, let's talk about your experience. Can you briefly tell us where you are in your RMS journey?
Absolutely. I was diagnosed my last year of college. I had my first relapse in December 2021. I wanted a treatment with powerful efficacy that I could take on my own. I started KESIMPTA first line in January of 2022. It's my only treatment. It's been great.
I'm so glad to hear that. Let's turn to the pivotal trial data. We'll start with relapse reduction. That's exactly what KESIMPTA demonstrated in pivotal trials. For the primary endpoint, annualized relapse rate, the powerful efficacy of KESIMPTA delivered reductions of up to 58% versus Aubagio. And here's what's so compelling. This was the equivalent of one relapse every 10 patient years.
One relapse every 10 years. When my doctor told me that, I was like, wow, I'm impressed. Having confidence in my treatment choice feels awesome, especially at this stage of my life.
I can imagine. And as you know, it's not just about what you may actively feel, which brings me to my next endpoint, KESIMPTA MRI activity data, which is even more impressive. KESIMPTA show a reduction in mean gadolinium-enhancing T1 lesions of up to 98% versus Aubagio.
98%?
That's right, Caylee. Near total suppression of T1 lesions. And for new or enlarging T2 lesion, KESIMPTA demonstrated reduction of up to 85% versus Aubagio.
It's so reassuring to me, just like the safety profile.
Exactly. KESIMPTA has an established safety profile that's been demonstrated over 6 years.
I remember my neurologist talking a lot about the KESIMPTA safety profile when we discussed it as an option for me.
It's so important. Today, we'll just scratch the surface of the KESIMPTA safety story, but I encourage my colleagues to take a deeper dive into topics like the KESIMPTA data on immune system maintenance, as 97.2% of patients had IgG levels above the lower limit of normal for up to 6 years. But let's get back to the safety profile. These data give me confidence in prescribing KESIMPTA first line. The pivotal trials show that the overall rate of infections and serious infections in patients treated with KESIMPTA was similar to Aubagio.
What did it show about safety long-term?
Great question, Caylee. The ongoing extension study has shown the most common adverse events being infections such as COVID-19, nasopharyngitis, upper respiratory tract infection, and urinary tract infections. Most serious infections, over 90%, resolved.
Very interesting. I remember talking about the pen with my doctor.
Yes, some patients are hesitant about a self-injection, but after we practice with the demo pen in my office, they feel more confident for good reason. The incidence of systemic injection-related reactions was already low with the first dose, 14.4%, and it decreased with subsequent injections. By the third dose, injection-related reactions occurred in fewer than 3% of patients.
I believe it. I haven't had any trouble taking KESIMPTA, and I love the pen.
You're not alone, Caylee. In a real-world survey, approximately 90% of patients found the KESIMPTA pen easy and simple to use. It's a simple, when you're ready to inject, even at home.
Being able to take it on my own, at home, or on the go really makes me feel like I'm in charge of my RMS.
And that's a great way to wrap this up. Caylee, thank you for sharing your experience with us. Thanks for joining. Please keep watching for the full important safety information and keep an eye out for more videos about KESIMPTA. You can always dive deeper into the data at KESIMPTAHCP.com.
Indication and important safety information. Indication. KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. Important safety information. Contraindications. KESIMPTA is contraindicated in patients with active hepatitis B virus, HBV, infection, or history of hypersensitivity to ofatumumab, or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions. Infections. Serious, including life-threatening or fatal, bacterial, fungal, and new or reactivated viral infections have been observed during and following completion of treatment with anti-CD20 B-cell depleting therapies. The overall rate of infections and serious infections in KESIMPTA-treated patients was similar to teriflunomide-treated patients, 51.6% versus 52.7%, and 2.5% versus 1.8% respectively. The most common infections reported by KESIMPTA-treated patients in relapsing MS, RMS, trials included upper respiratory tract infection, 39%, and urinary tract infection, 10%. Delay KESIMPTA administration in patients with an active infection until resolved. Consider the potential increased immunosuppressive effects when initiating KESIMPTA after an immunosuppressive therapy, or initiating an immunosuppressive therapy after KESIMPTA. Hepatitis B virus. Reactivation. No reports of HBV reactivation in patients with MS treated with KESIMPTA. However, HBV reactivation, in some cases resulting in fulminant hepatitis, hepatic failure, and death, has occurred in patients treated with ofatumumab at higher intravenous doses for chronic lymphocytic leukemia, CLL, than the recommended dose in MS and in patients treated with other anti-CD20 antibodies. Infection. KESIMPTA is contraindicated in patients with active hepatitis B disease. Fatal infections caused by HBV in patients who have not been previously infected have occurred in patients treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. Perform HBV screening in all patients before initiation of KESIMPTA. Patients who are negative for HBsAg and positive for HB core antibody, HBcAb+, or are carriers of HBV, HBsAg+, should consult liver disease experts before starting and during KESIMPTA treatment. Progressive multifocal leukoencephalopathy. No cases of progressive multifocal leukoencephalopathy, PML, have been reported for KESIMPTA in RMS clinical studies. However, PML resulting in death has occurred in patients being treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. In addition, JC virus infection resulting in PML has also been observed in patients treated with other anti-CD20 antibodies and other MS therapies. If PML is suspected, withhold KESIMPTA and perform an appropriate diagnostic evaluation. If PML is confirmed, KESIMPTA should be discontinued. Vaccinations. Administer all immunizations according to immunization guidelines. For live or live attenuated vaccines, at least 4 weeks, and whenever possible, at least 2 weeks prior to starting KESIMPTA for inactivated vaccines. The safety of immunization with live or live attenuated vaccines following KESIMPTA therapy has not been studied. Vaccination with live or live attenuated vaccines is not recommended during treatment and after discontinuation until B-cell repletion. Vaccination of infants born to mothers treated with KESIMPTA during pregnancy. For infants whose mother was treated with KESIMPTA during pregnancy, assess B-cell counts prior to administration of live or live-attenuated vaccines. If the B-cell count has not recovered in the infant, do not administer the vaccine, as having depleted B-cells may pose an increased risk in these infants. Injection-related reactions and hypersensitivity reactions. KESIMPTA can result in systemic injection-related reactions and hypersensitivity reactions, which may be serious or life-threatening. Injection-related reactions with systemic symptoms occurred most commonly within 24 hours of the first injection, but were also observed with later injections. There were no life-threatening injection reactions in RMS clinical studies. In the post-marketing setting, additional systemic injection-related reactions and hypersensitivity reactions have been reported, including anaphylaxis, angioedema, pruritus, rash, urticaria, erythema, bronchospasm, throat irritation, oropharyngeal pain, dyspnea, pharyngeal or laryngeal edema, flushing, hypotension, dizziness, nausea, and tachycardia. Most cases were not serious and occurred with the first injection. Symptoms of systemic injection-related reactions may be clinically indistinguishable from acute hypersensitivity reactions. The first injection of KESIMPTA should be performed under the guidance of an appropriately trained healthcare professional. If systemic injection-related reactions occur, initiate appropriate therapy. Patients who experience symptoms of systemic injection-related reactions or hypersensitivity reactions with KESIMPTA should be instructed to seek immediate medical attention. If local injection-related reactions occur, symptomatic treatment is recommended. Reduction in immunoglobulins. As expected with any B-cell depleting therapy, decreased immunoglobulin levels were observed. Monitor the levels of quantitative serum immunoglobulins during treatment, especially in patients with opportunistic or recurrent infections and after discontinuation of therapy until B-cell repletion. Consider discontinuing KESIMPTA therapy if a patient with low immunoglobulins develops a serious opportunistic infection or recurrent infections, or if prolonged hypogammaglobulinemia requires treatment with intravenous immunoglobulins. Liver injury. Clinically significant liver injury, without findings of viral hepatitis, has been reported in the post-marketing setting. Signs of liver injury have occurred weeks to months after administration. Patients treated with KESIMPTA found to have an alanine aminotransferase or aspartate aminotransferase greater than 3 times the upper limit of normal, ULN, with serum total bilirubin greater than 2 times the ULN, are potentially at risk for severe drug-induced liver injury. Obtain liver function tests prior to initiating treatment. Monitor for signs and symptoms of hepatic injury during treatment, including new or worsening fatigue, anorexia, nausea, vomiting, right upper abdominal discomfort, dark urine, or jaundice. If symptoms of liver injury are reported, measure serum aminotransferases, alkaline phosphatase, and bilirubin levels. Discontinue KESIMPTA if liver injury is present and an alternative etiology is not identified. Fetal risk. Based on animal data, KESIMPTA can cause fetal harm due to B-cell lymphopenia and reduce antibody response in offspring exposed to KESIMPTA in utero. Transient peripheral B-cell depletion and lymphocytopenia have been reported in infants born to mothers exposed to other anti-CD20 B-cell depleting antibodies during pregnancy. Advise females of reproductive potential to use effective contraception while receiving KESIMPTA and for at least 6 months after the last dose. Most common adverse reactions. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions.